Alaikum. Hamid Jalilian. I'm at University of California in Irvine, and I'm going to be talking to you about otologic migraine. Here are my disclosures. These are all unrelated to the topic we will be discussing. Mostly they are software and hardware related to other ear conditions. Just so you get an idea where Irvine is, so this is a map of the United States and this is California. And Irvine is located in Southern California between Los Angeles, which is here, and San Diego, which is down here close to the Mexico border. And where we're located, we're about maybe 5 or 6 kilometers from Disneyland. So Disneyland is very close to our hospital. So first we're going to talk about pathophysiology of migraine. Migraine is basically at its most basic form, a baseline hypersensitivity of the brain. So people who are carrier of the migraine gene or genes, their brain is sensitive, and there are many neurotransmitters involved in this process of migraine, including glutamate, serotonin, histamine, CGRP, which is calcitonin gene-related protein. And if we look at a vestibular nucleus neuron, you see that there are many different neurotransmitters, including acetylcholine, serotonin, histamine, glycine, GABA, dopamine, glutamate, as well as other molecules that affect the vestibular nucleus cell. So the way a migraine starts, it starts with a chemical change, which then leads to an electrical change. The electrical change in the brain is a decrease in electrical activity. So I always tell patients that it's the opposite of a seizure. So a seizure is an increase in activity. A migraine is a decrease in brain activity. That decreased brain activity then spreads within the brain, and depending on the areas it affects, it will create different types of symptoms. This then starts this process of activation of the trigeminal neurovascular phenomenon, which causes some changes in vascular flow and some neurogenic inflammation. That then leads to the headache and the other manifestations that we see oftentimes in the inner ear. In addition, it has some central vestibular effects, which then cause some of the symptoms that we tend to see with migraine. So trigeminal nerve is actually very intimately involved with the inner ear. There were a series of good studies that were done by Fred Nuttall and his group, and they took the first branch of the trigeminal nerve, so V1, the ophthalmic branch, and they stained the ophthalmic branch at the trigeminal nucleus, and then looked to see where all they would see the staining that would correspond to the branches of the V1. And as you can see, they found that the branches of V1 went to the basilar artery, ICA, and the arteries that supply the cochlea and the vestibule. And this is actually histology from their study looking at the cochlear blood vessels. And this is the spiral medullary artery, where you can see that there's extensive staining. So there are extensive branches of V1 around the spiral medullary artery inside the cochlea. In addition, there is significant staining of V1 in the stria vascularis, indicating that there is tremendous nerve endings from the trigeminal nerve within the cochlea. Now, they took it a step further, and what they did was they stimulated the trigeminal nerve by using electrical stimulation and using capsaicin. Now, what they found was, this is the sham group. This is no stimulation, and this is sham stimulation. This is the control, control and sham, control and 0.1 milliamp. And this is looking at the concentration of a molecule that comes out of the blood vessels. So this shows that there is fluid extravasation inside the cochlea when stimulated at the trigeminal nerve. And the more you stimulate it at 1 milliamp, the more fluid came out of the blood vessels and into the cochlea. Now, what this means is that trigeminal nerve stimulation causes changes in the fluid dynamics inside the cochlea. So you can see that this could potentially be the cause of some of the things we see in the inner ear, like endolymphatic hydrops, Meniere's disease, and even benign positional vertigo. Now, when you look at the general population, the migraine is present in about 13 to 25% of the individuals. Now, when we look at the general population, the 13% tends to be more on the lower end, which is mostly probably males, and 25% is mostly on the higher end with the females. And the reason for that is females, because of hormonal changes, tend to manifest migraine symptoms more often. And men, because of lack of hormonal changes, will usually, even if they're carriers, may not necessarily manifest their migraine symptoms. So genetically, men and women are probably inheriting the migraine genetic background equally, but men tend to manifest it less because they get less hormonal changes. Now, of that population of patients with migraine, about somewhere between 27 and 42% will get vertigo at some point in their life. So that translates to about 3 to 5% of the general population gets vestibular migraine or gets vertigo related to migraine. And actually at the highest end, it's probably about 10% of the general population. So if you think about 40% of that 25%, that would be up to 10% of the population. So I estimated these with the low number. Now, when you look at Meniere's disease, and the prevalence in the general population is about 2 in 1,000 individuals. So you think about how often you see patients with vertigo and how often you're making diagnoses of Meniere's disease and vestibular migraine. You should be making the diagnosis of vestibular migraine about 20 times approximately more than you're making for Meniere's disease. So for every 20 patients with vestibular migraine, you should be making one diagnosis of Meniere's disease, unless you have a very, very unique practice where you're only getting patients with quote-unquote Meniere's disease. So just if your ratio of diagnosis is way different and your diagnosis many more patients as Meniere's disease, you're probably underdiagnosing migraine potentially. Now, 36% of vestibular migraine patients will get their vertigo during times where they have no headaches. And as I will talk to you more, is you will see that there are many patients with vestibular migraine who never get headaches in their life, and the vertigo is the sole manifestation of their migraine. So you don't have to have headaches to have vestibular migraine at the time of the diagnosis. So many symptoms of atypical migraine surround the ear, and that probably is because of the significant involvement of the trigeminal nerve with the ear. We see some eye symptoms, of course. We know about auras without headaches and other kind of retinal issues, but we also see a significant amount of ear-related stuff. Now, keep in mind that there are sort of two worlds when it comes to migraine. There is the classic migraine, which is about half the patients or 40% of the patients. And there are the so-called atypical migraine patients. The atypical migraine patients are patients who do not fulfill the International Headache Society criteria, but have many of the symptoms that are associated with migraine. So they're triggered by all the same symptoms. It's just that they don't fulfill those exact criteria that have been set out by the IHS. Now, those patients can get neck spasms or stiffness, especially one-sided. A lot of times patients will come in having had an extensive workup of their neck with multiple MRIs because they get a stiffness on one side. As usually the stiffness tends to be on the same side as all their other symptoms that are ear related. So if they have ear pressure or benign positional vertigo or Meniere's disease, etc., then it's always on the same side. Not always, but almost always on the same side. Other things that patients will complain about is that they say they get a lot of sinus headaches. And when you ask them, do you get migraine headaches? They say, no, I get a lot of sinus headaches. And there's a very good study that came out some time ago where they looked at a population of chronic sinus headache patients, and 88% of them had migraine. So sinus headache is just another manifestation of migraine headaches that tends to be around the forehead, and the areas of the maxillary sinuses. So it's sometimes interpreted as being a sinus problem when it's really a migraine problem. Patients can complain of pain behind their eyes. They said it sometimes hurts to move the eyes. They said that, well, I don't get headaches. I get caffeine headaches, or I get a stress headache, or I just get head pressure. But these are all just forms of migraine at different degrees. So if you think about just like every condition, nothing is a singular condition. Everything has kind of a spectrum to it. And at the sort of highest end of the spectrum are patients who get the classic migraine. And on the other end of the spectrum, you're going to get patients who get symptoms primarily from things like stress and caffeine withdrawal, etc. Now, you'll see patients will say, I get sinus infections when I'm in front of an air conditioner, or if there's weather changes, I get sinus infections. And so they a lot of times attribute this to an allergy, but the reality is actually these are really migraine headaches that they are getting because atmospheric pressure changes cause migraine headaches, and stimulation from cold can potentially trigger migraine. So you cannot get a sinus infection from the air conditioner. You can get a migraine from an air conditioner, but not a sinus infection. People can say that they have dizziness with weather change, or if they get overstimulated by sound, that can trigger their dizziness. There are patients who will come and say that they've had multiple sinus surgeries, but they still get sinus pain, oftentimes in the frontal. And when you look at their scans, pretty much they've had every variation of the Droff procedures, and they've had their entire sinus drilled out, and they still are getting symptoms. And when you look at the scans, there is maybe a little bit of thickened mucosa, and so sometimes an unknowing surgeon can think that that's what's causing the pain, and will keep going after that little bit of mucosa, thinking that that's causing the pain, when the reality is the problem is really a migraine problem. Sometimes patients will say, well, I know it's a sinus infection because I got sinus surgery and then my pain went away for 6 months. And that's because a lot of the nerve endings are removed during this surgery. And because of that, the symptoms get better. And then the nerve endings will start growing back. And after about 6 months, they're back to normal and they'll start getting the symptoms again. The other is that you'll see is patients will say, I know it's a sinus infection because when I take an over-the-counter decongestant like pseudoephedrine, my symptoms get better. And that can sometimes be because of the vascular dilation that occurs as an end result of the migraine pathway. And they end up getting vasoconstriction with their pseudoephedrine, and therefore they feel better. But that's not because it's a sinus infection. So what are some triggers for migraine? Migraine triggers include stress. Stress could be in the form of psychological stress, like patients who have anxiety, or they have some conflict at work or home, or death of a relative, that can sometimes be the starting point of their symptoms. Or it could be physical stress because of a back pain or upper respiratory infection. Or a lot of times you see patients who get this after dental procedures where there's significant pain stimulation to the trigeminal nerve, or after eye surgery. I always ask the patient, anything happen in your life before your symptoms started? And this is one of the easiest ways to identify the trigger and then try to work on eliminating it. The next is hormonal changes. Oftentimes when people are younger, they can get symptoms more around their menstrual cycle, but a lot of times with vestibular migraine, we see patients where they present around menopause time. And I always try to explain to patients that menopause is not a singular time event. Menopause is about a 5 to 10 year process. It starts a few years before and it ends a few years after the patient stops having their menstrual cycle. So just because someone is 48 and is having a menstrual cycle does not mean that they're not perimenopausal. So perimenopausal changes to hormones can trigger migraine symptoms. Hormone replacement therapy, oral contraceptives, and even in men, I've seen it as a result of testosterone supplementation. Anything that causes an unnatural up and down in hormones will potentially be a trigger for migraine. Changes in sleep, so if somebody sleeps too much or too little, that can be a trigger. An interrupted sleep, so people who wake up multiple times during the night, people who have obstructive sleep apnea, and it's something that it's really important to screen for in patients with migraine to make sure they don't have obstructive sleep apnea, and if so, treat it. Patients who sleep too much, so they wake up late on weekends, and then wake up early on weekdays, that can be a potential trigger. Patients who do shift work, like for example nurses, where they sometimes work nights, sometimes they work days, or they work 5 or 6 nights at night, and then that one day they're home, they try to be up during the day with their family, and so they completely shift their sleep schedule again. Patients who travel a lot and their clock changes constantly, that is also another potential trigger. Head trauma or intracranial surgery, so any irritation to the dura and subsequent changes to the trigeminal nerve can be triggers. As I mentioned, surgery or dental work, but any type of surgery can be trigger, and that's primarily because people tend to fast the night before, so they don't eat, they don't drink, so they get dehydrated, they get hungry. They usually don't sleep very well the night before because they have to wake up early oftentimes. They usually have some stress associated with the surgery, and so all of those things together lead up to it. We see a lot of patients with migraine can be triggered after ear surgery, specifically stapedectomies, and we'll talk about that a little bit later because of the significant vestibular stimulation. Diet is a significant trigger, and it's something that's really important to understand well and to educate patients about. The diet, I tell patients, has 2 parts. One is the timing of eating and drinking water. So we want people to eat on time and not go hungry for an extended period of time, and to also do everything they can to prevent dehydration, to drink lots of water during the day. I tell patients to not drink water for 2 to 3 hours before going to bed, or don't eat any fruit for a couple hours before bedtime, because drinking lots of fluid can cause the multiple wake-ups during the night and lead to disruption in sleep. Now, the next part is really certain foods that are triggers for this. And these are foods that are aged or have a molecule within them that is neurotransmitter-like. And those include things like histamine, glutamate, tyramine, among others. Probably by far the most common food trigger is caffeine. So I tell patients to gradually go off of caffeine. Unfortunately, caffeine causes a lot of ups and downs in the brain because there is a lot of withdrawal effect. And so that tends to be a problem and cause migraine. The brain, and especially in patients with migraine, likes things in a very regimented way, likes to eat at the same time every day, drink the same amount of liquids every day, sleep around the same time, wake up around the same time, everything kind of be the same. It's sort of, I tell patients, the brain likes life to be boring. The more changes you make on a day-to-day basis, the more the brain creates a stress reaction, which then can cause your migraine to become persistent. So we want patients to get better, and then they can resume what they used to do once they are better. But while they're trying to get better, they should try to live a what I call a boring life, and eating at the same time and drinking lots of water and sleeping at the same time. Probably after caffeine, things like chocolate and nuts are very common triggers. Alcohol, but really it's the tyramine in alcohol as a result of fermentation. We see it very commonly in red wine or other kind of wine or beer, but we don't have it with very purified alcohol like vodka. So the actual alcohol is not a problem. It's really the tyramine that's in a lot of alcohol is the problem. Cheeses tend to be an issue. Fresh breads, yeast products, any kind of processed meat or protein of any kind. MSG, which is monosodium glutamate, and is a preservative that's used in a lot of foods that are preserved, like frozen foods, canned foods, ready-to-eat packaged foods, so like chips and uh, packaged nuts, things like that. A lot of times have MSG in them. Anything that's pickled or preserved because of the production of tyramine. Aspartame, which is the artificial sugar that's NutraSweet, that's in like Diet Coke and Diet Pepsi, etc. Certain types of vegetables, like lima beans, some fruits, any fruit that is overly ripened. So avocados, figs, and raisins are common. In raisins partly because they're aged as well. Bananas because of tyramine, citrus fruit because of histamine, or any, as I said, overly ripened fruit. So I tell patients that a hard peach does not contain a lot of tyramine, but a soft peach has a lot of tyramine, and so they have to avoid overly ripened fruits. Now, the last part of the stimulations last part of the triggers is intense stimulations. With dizziness, most common stimulations that trigger dizziness are a lot of head motion or visual motion, so looking at things that move. Some people are sensitive to sound. Some people are sensitive to weather changes where there is low pressure. So when there is a storm coming, when it's cloudy or rainy weather, or when people travel to mountains and the atmospheric pressure is lower. Some people are sensitive to ambient heat. When they get overheated, that triggers their migraine and then dizziness and whatever symptom. Some people, they get a cold on their face or their ear. So some patients will come and say that whenever cold air hits my ear, I'll get an intense ear pain. And that's really a migraine-related phenomenon. Some people are triggered by intense exercise. And then others are in bright lights are potential triggers. Now, visual motion, some examples that I bring to patients is scrolling on a computer screen, going to a movie theater or three-dimensional movie, scrolling and reading on the phone, walking and reading on the phone, anything that causes significant strain on your eyes to try to focus while the screen is moving is a potential trigger. Some people are triggered with motion in their peripheral vision. For example, if there is a ceiling fan or windshield wipers can sometimes be triggers. So think of migraine when patients have unusual degree of light or sound sensitivity. They say that even if it's cloudy, I can't go outside without sunglasses. They say that even a little bit of noise is too annoying, and sometimes they say they can't even hold the cell phone next to their ear because it's too loud for them. They say that the traffic noise is very bothersome to him. Sometimes, as I mentioned, the sensitivity in visual fields, if they watch like a sports game on TV, or they get dizziness in the supermarket, ceiling fan, as I mentioned before. People who get motion sickness as an adult, or they had motion sickness as a child, that indicates that they have the genetic background for migraine. And we recently published a paper on motion sickness and migraine and the significant connection between the two. These are people who say that they cannot sit in the back seat of a car or on a cruise or boat will develop problems with dizziness and motion sickness. Some patients will describe the space and motion discomfort where they go from an enclosed area, like inside of a building, to the outside. That suddenly causes them to be dizzy. When they look upward, sometimes they could get dizzy. Or they go from an outside open environment into a closed environment. That can sometimes create it. So patients sometimes they say, when I was walking outside to get to the clinic, I didn't have a problem, but once I entered the opening the door where it's a more enclosed area, then they felt dizzy over there. Patients who have excessive nausea, and I've had patients who only presented with excessive nausea. Of course, nausea is one of those things you need to do fully worked up. They need, of course, brain imaging and they need GI workup, but we need to make sure that they don't have a migraine issue, which they often can. So think of migraine in patients who have ear pain or ear pressure once you've kind of ruled out every other cause. Patients who have headaches, wind and dizziness, people who have a pressure sensation in the ear that does not resolve with Valsalva, and they've had a myringotomy in the past even, or a tube placement, or they don't have superior canal dehiscence. Those are most likely migraine patients. You look at the tympanic membrane, it looks pristine. There's no retraction. The patient says they pop their ear for a fraction of a second, they feel better, but then after that, the plugging continues. Patients who say that they have the sinus headaches with repeated normal CTs or lack of response to treatment. This was described by Schreiber, as I mentioned, and this is one that 88% of sinus headache patients are migraine sufferers. Patients who get low frequency or fluctuating hearing loss, think migraine. There was a good paper by Huang et al., and my colleague and I wrote an editorial about it in JAMA Otolaryngology a couple years ago, something that we have observed for many years. If you think somebody has Meniere's disease, it's most likely a migraine phenomenon, and we'll talk about all of these as we go forward. So patients who say they feel dizzy with loud noise, but they don't have superior canal dehiscence, they don't have a perilimb fistula, they don't have any other dehiscences between the cochlea and other structures around it. Patients who get recurrent benign positional vertigo that may or may not respond to Epley maneuver and they have a normal MRI. Patients who have vertigo and their MRI is normal and they don't have BPV, they most likely have a migraine problem. Sometimes patients get dizzy when you do a Dix-Hallpike, but when you look at their eyes, they have no nystagmus, but they feel dizzy when they're lying back. Patients who get severe nausea or vomiting after Epley maneuver, think a migraine. Patients who get immediate nystagmus on Dix-Hallpike, there's no delay, think migraine. Now, this is what I try to use to explain to patients how migraine works. And I tell them that there's a threshold in the brain where this is this migraine threshold. And because of various things, the brain activity will start getting up to the point where it reaches the threshold. Now, that could be caused by some stress and then hormonal changes, a little bit of poor sleep, and a little bit of the diet will push them over. And they'll get a symptom, they'll have the symptom for a few hours or a few days or sometimes a few weeks. Then the brain naturally wants to come back down to its normal state, but then it could be triggered up again because of a dietary factor or another factor. And this will intermittently continue until the triggers somehow are diminished, so the stress improves, or luck, some by sort of stroke of luck, their diet improves, or they start drinking more water or something, and the brain naturally goes back to its normal state, and they'll eat the same stuff and they won't get symptoms. So the patients sometimes say, why do I have to not eat bananas now when I used to eat bananas since I was a child and I never had problems? And I explain to them that right now you're at a much more elevated state, so you're very close to your migraine threshold, and any little trigger can push you over. So now we have to be very careful with the diet. But once you're better and you haven't had symptoms for a long time, then you can resume your diet and go back to where you were. Now, sometimes patients can have continuous migraine symptoms for months at a time. So patients say, well, this can't be a migraine because I've had these symptoms for 3 months or 6 months or a year or two. So I tell them that this is how it works. Something triggered you, you got above the threshold, you started getting symptoms. But whatever is triggering you continues to be there. That could be diet, it could be sleep, it could be stress, it could be whatever. But something is maintaining you on a constant basis. And that is what we need to eliminate in order to get people better. Now, some patients have multiple thresholds, so they sometimes get headaches at certain times in their life, and then later, or depending on how much they're triggered, they get more activity in the brain, and then they reach that vertigo threshold. Now, trigger control is what brings the brain activity back to normal. Prophylactic medications that we use is really intended to elevate the threshold. So this is the effect of medications. We just move the thresholds up, so then the patient is still continuing where they were, but they will still, they won't get symptoms of vertigo, for example. But if you were to take the medication off, you come back down and then they'll start getting triggered again. So trigger control is really the best way to control migraine. And then medications we use to help give the patient relief. Sometimes when the patient has continuous symptoms like this, it's very difficult for the patient to determine what their triggering factors are. So as the threshold is moving up, then they will reach a point where the symptoms will become intermittent, where between episodes, the activity drops below the threshold and they will have relief. And once they're triggered again, then that's the time to determine what happened that caused the trigger. And usually, most of the time, it's within 6 hours of onset. So if, let's say, the threshold is here and the patient gets above the threshold here, at that time, let's say it's 3 p.m., they got to look back 6 hours. What happened during those 6 hours that triggered their vertigo? Was it that they got stressed? Did they have something to eat? Did they get dehydrated? Did they go hungry? Did they get overstimulated? Did they have poor sleep? All of those are the factors that need to be looked at. Now, a few years ago, we went back and looked at Menier's original papers that he wrote in French. So we looked at the French translation, French, and translated into English, and there was another translation that we looked at to correspond with our translation. And what Menier described is, this is actually exactly from Menier's papers, that he described a cerebral state called migraine that gives place in the end to similar attacks, and the deafness which arises in these circumstances would seem to us inevitably to be related to a disease of the same nature, meaning that, he said, migraine is the cause of this, it appears, but he thinks that it was something else that's causing the hearing loss. And then he also talked about that we believe that it can be asserted that many so-called migraines are only the index of a morbid process leading infallibly to deafness. So Menier mentions migraine, and Menier mentioned migraine in his papers multiple times. Now, as you know, when Menier actually died, afterwards is when the condition was named Meniere's disease. And as oftentimes happens, unfortunately, sometimes people don't go and read the original papers. And we see that in the literature currently, where people are quoting a paper in their paper, but they actually never read the actual paper. They're quoting it out of another paper that's quoting them. So it becomes a secondary reference. Nobody ever looks at the original reference. And so this pretty much had died because nobody had looked into this. And so when we looked into it, we found that even Meniere himself thought that Meniere's disease, as we call it now, is caused by a migraine-related phenomenon. So we started looking at our patients with definite Meniere's disease based on criteria. And when we looked at these patients and have them fill out surveys and interviewed them, 68% of them, of the patients with Meniere's disease, had a history of migraine headaches. The other 32% of the patients had either a family history of migraine in a first-degree relative. They had migraine features, which included things like three sensitivities, like light, sound, motion, visual motion, weather, or smell sensitivity, or things like they get ice cream headaches, or they get caffeine withdrawal headaches, and things like that are migraine-related events, like motion sickness. So then we took it a step further, and we thought, let's take these patients with Meniere's disease and treat them with medications intended to treat migraine. So we took 26 patients with definite Meniere's disease and prospectively evaluated them. We treated them with purely a migraine protocol and not any of the treatment that is given for Meniere's disease. All the patients had previously had diuretic treatment by other physicians, and they had failed. We started with either nortriptyline or verapamil, and then added topiramate if they didn't get better. We did a survey called Meniere's Disease Quality of Life Survey in the beginning and then follow-up. And 92% of the patients improved from their Meniere's symptoms, and they went from a mean of 8 episodes per month before and to 0.6 episodes per month after, on average. So Meniere's disease patients respond very well to migraine treatment, and the response is really equivalent to vestibular nerve section. This is a table from our paper, and this is various authors and what their treatment has been. This is endolymphatic sac, this is intratympanic steroid and intratympanic gentamicin. Here you see vestibular nerve section, and then this is ours with migraine treatment. We used some of the same surveys that the other authors had used, and the response to treatment, ours 92, and when you look at the various other authors with vestibular nerve section, is between 90 to 96. So we're about the same level as a craniotomy with using a migraine therapy. As we started seeing more and more of these patients, we started looking into migraine as the cause of a lot of other symptoms that we saw that are associated with dizziness. Those include management of mal de débarquement. So, as you know, mal de débarquement are patients who have a persistent sensation of dizziness or motion after a boat ride or an airplane ride. And these patients have been very difficult to treat traditionally. So we looked at 15 of our patients, and we treated them with the migraine protocol. We used a historical control group where we used to send these patients to physical therapy. Most of the patients are female. The mean age is 51, which is around menopause time, which is very common. The patients after treatment went from a symptom level of average of 7.6 to 1.8 in terms of intensity of symptoms. The control group, which had the physical therapy, went from average of 7.4 to 6.8, so not a significant improvement. And we had a pretty long follow-up on these patients. Now, when we looked at the patients with mal de débarquement syndrome, when we looked at the various things that they have And we looked at, for example, motion sickness. We see that a significant portion of them had motion sickness. 87% of them had a history of headaches when they were exposed to wind or air conditioning, or they had allodynia, or ice cream headache, meaning when they get a headache when they eat something very cold. And 73% of them fulfilled the International Headache Society criteria for migraine headaches. Another condition that we've found to be associated with migraine is hyperacusis. We looked at a group of 18 patients with hyperacusis. We treated them with the migraine protocol. We had a group of 17 patients who were historical controls that we treated with progressive broadband noise sound therapy. We didn't use sound therapy on our migraine treatment group. We looked at the modified Halfa score, which is a questionnaire that's used for diagnosis of hyperacusis. Normal is less than 27. The treatment group went from 32.6 to 22.2. The control group, which was the sound therapy group, went from 33.9 to 27.6. So much more significant an improvement in our migraine treated group. Some other work we've done related to migraine is looking at oral pressure. We originally reported this 11 patients where these are patients who have persistent pressure sensation in the ear. They have a normal tympanic membrane. They have a normal CT scan and MRI indicating no tumor or no canal dehiscence or cochlear dehiscence of any kind. The patients had undergone either a myringotomy and tube in the past or a myringotomy with a needle to see if they would get improvement, and none had improvement. And then when we treated them with migraine therapy, we had 7.2 in terms of intensity out of 10 go down to 1.5 intensity out of 10. 91% of these patients had visual motion sensitivity. So these are patients who are sensitive to a lot of motion, indicating their underlying migraine issue, and 54% of them fulfilled the Headache Society, International Headache Society criteria for migraine headaches. Pediatric dizziness, if MRI is negative, it's migraine until proven otherwise. We actually had a patient with definite Meniere's disease. This is a patient at presentation, had a normal hearing in the right ear, had a pretty significant low frequency sensory neural loss, almost a flat loss, but mostly in the low frequencies. This patient was only treated with migraine diet and lifestyle changes and vitamin B2 and magnesium, so riboflavin and magnesium that are used for treatment of migraine. And this patient had this hearing loss for 6 months, and on follow-up had no dizziness episodes, and pretty much closed the gap between the two ears. The patient actually did well for a long time, had no symptoms. About a year and a half or so later, they came back to me, and she'd had another episode, but at that point, again, had gone to a birthday party, had a lot of overstimulation, had a lot of the foods that they're not supposed to have, like chocolate and pizza, etc., and that triggered another episode. But the hearing, fortunately, remained well. We had another group of 5 patients with persistent post-stapedectomy vertigo. Some of these were patients that we operated on. Most were patients that came from other physicians. And we did a blood patch procedure where we inject blood behind the tympanic membrane to seal up any perilimb fistulas. They had a CT scan and ruled out a long prosthesis. 3 had a history of migraine headaches. 2 had pressure sensitivity with their vertigo. So they said when there were pressure changes, they would get dizziness or they would burp. That would make them dizzy. But when we looked at the scan, it was normal. We treated them with the migraine protocol and they all improved. One patient particularly that had the pressure sensitive vertigo was very classic for a long prosthesis, but the CT scan looked normal. Her symptoms did not start until 6 months after the surgery. And when we started her, she started on nortriptyline. We went up to 50 milligrams and her symptoms completely resolved. Then we reduced the nortriptyline to try to get her off of it. And when we went down to 25 milligrams, she started getting symptoms again. So we kept her at 30 milligrams for another couple months, and then eventually took her off, and she did just fine. So we know it wasn't a long prosthesis because number one, it wouldn't have gotten better with nortriptyline, and number two, it wouldn't have stayed better once she was off the nortriptyline. Now, migraine and hearing loss has been a topic of a little bit of controversy, and I will make the argument in the next few slides that migraine can cause hearing loss and is a significant cause of sudden hearing loss. So let's talk about this. So this is a study by Kim and colleagues looking at 45,000 patients with migraine and 180,000 non-migraine patients, and that migraine patients were 50% more likely to get sudden hearing loss. Chu looked at 10,000 migraine patients and 41,000 control patients, and they found that migraine patients were 80% higher chance of developing sudden hearing loss. Now, migraine and sudden hearing loss is not a new concept. Newt Coker and Herman Jenkins back in 1987 described migraine and sudden hearing loss, where they had a case report of patients who get recurrent sudden hearing loss, and they would get a simultaneous migraine headache at the same time on the same side. So there is a new term that's being used called cochlear migraine to describe patients with hearing loss associated with this condition of migraine causing an effect on the inner ear. We think of otologic migraine as sort of the overlying umbrella condition that includes cochlear migraine, vestibular migraine, cochleovestibular migraine, which is what Meniere's disease is, and all the various things like ear pressure, ear pain, etc. Now, these are patients who get recurrent hearing loss, usually low frequency. There's no dizziness. They have a family history. They might have headache or neck stiffness symptoms. They might have motion intolerance, and they have some sensitivity to pressure changes. This is the article I was talking about, and this is our editorial about it. Now, we actually started treating patients with sudden hearing loss with migraine therapy a few years ago. And we looked at a historical control group of 47 patients who had oral and intratympanic steroids. And then we had another group where we started treating them with oral and intratympanic steroids and additionally treated them with migraine medications. And these are patients who had at least 30 decibel loss compared to the other side in 3 frequencies in a row. Now, what we found in the group that was treated with migraine prophylaxis had a significantly better low-frequency outcome when we used the adjuvant migraine medication, and they needed less number of injections. I usually do 2 injections, and if the patient gets better, but is not as good as they were, we will keep doing them. So we usually stop injections once they're either back to normal or there is no more improvement. So the patients needed less injections when they were treated for migraine. And you can see here the injection and migraine medication group had an average of about 10 to 15 decibel better hearing in the low frequencies compared to the patients who were treated with oral and intratympanic steroids alone. Now, this is a patient with sudden hearing loss that we saw when she came to us. This was the original audiogram. This is on March 26th of 2019, and this is what it was, 0% word understanding. The patient was treated with intratympanic and oral steroids, and came to us about 2 weeks later approximately. Most people at this stage would say there isn't much that could be done, and would just leave the patient alone. We started the patient on nortriptyline and topiramate. Again, baseline had 0% word understanding, so speech awareness, just heard a thumping sound, no speech. And the hearing threshold was between 80 to 95. This is about 5 weeks later at a dose of nortriptyline 75 milligrams, topiramate 150 milligrams. The low frequencies have come back to normal. The high frequencies have improved substantially, and the word discrimination has gone from 0 to 100% at a level of 75. Now, we started looking at some of the patients with chronic sudden hearing loss. These are patients who had had at least 3 months from the onset of their sudden hearing loss. We looked at a cohort of 21 patients. About half of them still had a pressure sensation in their ear. About 29% of them had a headache at presentation. The patients were treated with a combination of nortriptyline and topiramate over a 6-week period. The nortriptyline is escalated every 2 weeks. The topiramate is escalated every 1 week. If they did not have an improvement, we would do 2 intratympanic injections for them. When we looked at this cohort, 14% of them returned to baseline. Word discrimination improvement of over 15% was seen in 54% of patients, and the average word discrimination improvement was 35%. We had 7 of the 21 patients, so 33% of them, went from a non-usable hearing to usable hearing, and where they could use a hearing aid. So sudden hearing loss is a migraine-related phenomenon in the majority of the patients, and it responds well to migraine therapy, even when it's chronic. The patients that we found to respond the best are patients who had current migraine symptoms like oral fullness or headaches. This is an example of a chronic sudden hearing loss patient. This is a patient had an outside audiogram. You can see what the audio looked like for the left side, and had a 32% word discrimination. The patient came to us about 3 months after, and then this is the hearing test at that time, which is approximately the same as a little bit of drop in the low frequencies. 32% word discrimination. This patient was only treated with nortriptyline and topiramate, and at a dose of nortriptyline 25 and topiramate of 50, the patients had a significant improvement in the low frequencies from about 60 to 35, but more importantly, the word discrimination went from 32% to 80%, and this patient was able to use a hearing aid. Now, how do we treat migraine? Lifestyle changes is really probably the most important part of this. Strict adherence to diet. We usually have the patients eliminate all the bad foods, and then once they are better, they will start reintroducing the foods so they can identify which ones are triggers and which ones are not triggers for them. We tell patients to not skip meals, drink lots of water during the day until 3 hours before bedtime, as we mentioned before. We ask them to sleep the same schedule. If there is anything on their history or their anatomy that's suggestive of obstructive sleep apnea, we will check a sleep study on these patients. We ask the patients to do regular exercise and meditation for stress reduction. I have a very low threshold of sending these patients to a sleep specialist because many of these patients have insomnia or sleep apnea, and that really needs to be treated in order to help the patient. We ask the patient to perform the everyday activities and try to react less to stressful situations, because that's what tends to trigger these episodes. We put all the patients on vitamin B2, which is otherwise called riboflavin, 200 milligrams twice a day, and on magnesium, 400 milligrams twice a day. The magnesium forms that we use, most commonly we use oxide because it's easiest to find in stores. Magnesium glycinate is less likely to cause diarrhea. So if a patient gets diarrhea from oxide, we usually have them cut it in half, but if not better, they will go to glycinate. I will talk in more detail about treatment with medications in another talk. And thank you for your attention.